Welcome to Chapter 8. In this chapter, we're going to discuss language-based learning disabilities. What are they? Why might they develop? The characteristics, and then go into specific disorders of specific language impairment and auditory processing disorders. To start, I'm going to give you a few acronyms you are going to see in this chapter. LA stands for language age. MA stands for mental age, CA stands for chronological age, and IQ stands for intelligence quotient. By school age, a child should have developed conversation and basic narratives. For typical developing children, language skills in all 5 components of language should be age appropriate. So for those first 3 years in school, grades 1 through 3, the children are learning to read, write, and spell. So the child who has a language disorder may lag behind in reading and writing and spelling. These children do not have the foundational language skills to learn these subsequent skills. This is problematic because they only have until grade 3 to learn the foundational skills of reading, writing, and spelling. Once the child moves on to grade 4, they begin reading to learn. During reading, the child continues vocabulary growth, learns new complex and tactical structures, and complex narrative formats. All of this new learning comes through reading. Also in reading, they will learn new language forms such as expository language and persuasive argumentative language. Those are considered literate language forms because they are more complex, higher level. These are the types of writing and language forms they are reading in their textbooks. To answer the question, what is a language disorder for school-age children? Let's first talk about what constitutes a disorder. Doesn't matter what the disorder is in. A disorder is, number 1, not doing something. Number 2, when you're expected to do it, and it interferes with your daily life. So if someone has a voice disorder, they're not using their voice the way they're expected to be using it for their age, and it interferes with their daily life and their ability to communicate. So based on this information, what is a language disorder? Take a second. A language disorder is not using language at the age expected, and it interferes with their daily life functioning. Pretty simple, huh? Pretty simple concept, very complex disorder. Let's talk about it more. So here's a more formal definition of a language disorder in school-age children. It is a deficit in learning to talk, understand, or use any aspect of language appropriately relative to, number 1, norm reference expectations for children of a similar developmental level, and second, the environment. Let's discuss this a little further. So in Texas schools, we considered a standard deviation of 77 or below significant. That's about 1.5 standard deviations below the mean of 100. So if a child scores at a 77 or below on a language test, then we would consider that child to have a language disorder. However, you want to look at the environment. Is this child like other children in their environment? So one circumstance seen in schools sometimes is maybe a child who scores in the 70 to 75 range on their norm reference test, and the common assumption would be that the student is struggling with academics, right? Makes sense. To check this hypothesis, the clinician is going to talk to the teacher to see the child's academic performance level, talk with the student on his perceptions of his academic abilities, and how hard academics are for him, and then look at his environment as a whole. Do all of these factors match up? Sometimes the factors do match up and sometimes they don't. You could have a teacher report that a child with a language score in the 70 to 75 range be one of the best students in the class with no attention, academic, or social problems. So there is a disconnect, and you would not recommend services in that instance. You could have the same situation, and when you look at the environmental factors, you might see that this child is from maybe a lower socioeconomic area, or is having difficulty with social skills, but academics are okay. This child you would possibly recommend services there. As far as the lower socioeconomic area, if there was a disconnect between their everyday functioning, their ability to learn, the readily available components of the environment to help them learn and help support them in the learning process. And we've already talked about socioeconomic factors, is that they are more at risk. So I just wanted to give a little bit more detail on why I kind of said that before. For the rest of this chapter, we're going to look at 3 types of school age disorders: learning disability, specific language disorder, or SLI, specific language impairment, and auditory processing disorder, or APD. So what is a learning disability? Your book defines it as any one of the learning problems that affect the acquisition and use of listening, speaking, writing, reading, mathematical, and reasoning skills. Remember that a child will not have a learning disability until he gets to school. Therefore, learning disabilities are not usually diagnosed before 3rd grade, because we want to give the child a chance to learn and succeed with academics before making this diagnosis. We're now going to go into the specifics of a learning disability according to the definition of the Texas State Board of Education. According to the Texas State Board of Education rules, a student with a learning disability is one who has been determined through a variety of assessment tools and strategies to meet criteria for a specific learning disability. So first, the child does not achieve adequately for the child's age or meet state-approved grade level standards. So they're not performing as they are expected to. The child can have a learning disability in oral expression, listening comprehension, written expression, basic reading skills, reading fluency skills, mathematics calculation. Mathematics calculation is not language, but if you get into a word problem, it now involves language and reading comprehension. So then we also have reading comprehension and mathematics problem solving. So with mathematics problem solving, we can involve a higher language understanding. It requires more of a language understanding skills, higher level. The second part is when provided appropriate instruction, as indicated by performance on multiple measures or a process based on the child's response to scientific research-based intervention, the child does not make sufficient progress. Third, the child exhibits a pattern of strengths and weaknesses in performance, achievement, or both, relative to age, grade level standards, or intellectual ability. We will often see that they will be strong in some areas and weaker in others. For example, we could see a student who is strong in math and might be great in oral expression, but have trouble with reading fluency. So if you were to draw a graph of their scores, you would see an up and a down pattern in their different skills. Lastly, the symptoms are not a result of another disability, culture, economics, or limited English proficiency. A child with a learning disability will have an IQ that is within normal limits and cannot have another diagnosis such as ASD or Down syndrome. Approximately half of children diagnosed with LD have language and language-related disabilities, which can include disabilities in oral comprehension, oral expression, reading, spelling, or writing disabilities. So 50 to 80% of an SLP's caseload will be a disorder in one or more of these areas. The students are using labeled as speech impaired. So we're seeing that kids are labeled as speech impaired in the schools. I've always kind of thought that that is a little way actually behind the times because they label it, their diagnostic criteria is labeled speech impaired, but this is all about language. So I feel like they need to update that diagnosis there in the schools. So here's a visual to understand how they all relate. Here's a big circle, learning disabilities. And with that, most learning disabilities are language-based learning disabilities. That is the LD circle. Of those language-based learning disabilities, most of those are reading disorders. And of reading disorders, there's a large number of students of those who are dyslexic. So a child can have a reading disorder that could be grounded in comprehension in your fluency difficulties and not have dyslexia. Dyslexia has to do with decoding, matching the letters to the sounds. I am definitely a visual thinker, so I really hope this helps you see how these all interrelate. What are some risk factors that might be signs that a child has a learning disability? First are phonological deficits. Remember, a speech sound disorder can indicate that a child's phonological system is not solidified or real robust. They have difficulty producing sounds and maybe matching sounds. Because of those phonological deficits, evidence has shown the child will have trouble when it comes to reading. The next sign is a child who is seen as socially inept. This could be because the child is not comfortable with language and using his language. The child will have difficulty practicing and using social skills. We can also see a child who has trouble in the classroom with activities that involve language, such as following directions and being able to answer questions. If there's a family history of someone having a learning disability, this could be an indication that there is a group of genes in the family which result in a learning disability. If there are other family members, the child is often at risk. We also look to see if the child has had a speech and language disorder such as SLI in the past. The SLP might not know this because the child could have been discharged before beginning school. Of course, research has shown if an individual has a hearing loss or multiple ear infections, the recurrent middle ear disease where one has times where they don't hear very well, this can also be a soft sign. And then the history of ADHD. If a child can't pay attention, then learning will be affected, obviously. Next is poverty, which we've talked about before. The last is abuse or prenatal drug exposure. Physical or emotional abuse or prenatal drug exposure can impact the child by not providing the opportunities to learn language. I have seen that children with learning differences have several of those risk factors or difficulties. Growing up is hard, but then learning differences are added to this, and a child can develop a poor self-concept. And you know what? They just don't feel good about themselves. So think about yourself. When you're having to do something that's not easy or do something that's very hard for you, then you start to dislike it. That is what we often see with these children, is that they begin to not like school, which is such a shame. Because they don't enjoy learning and being at school, they begin to do things to get away from having to do the academics. So here's a question again. Is it ADHD or just avoidance of academic work because it's hard? Next, when a child begins to avoid is when behavior and conduct problems often begin. Lastly, like we have already discussed, the child without good language can have difficulty socializing. Obviously, not every person who has a learning disability has all of these problems. Hopefully, these impacts do not occur. What is hard as a child is that their job is learning and attending school. When a person becomes an adult, at least they can pick the work that plays off their strengths and motivation. A child with dyslexia, of course, would probably bypass jobs in which the dyslexia would impact. But at the school age level, they don't have a choice. They have to do the things that are hard, which is school. Let's now talk about how does school and academic demands change over time. In preschool, a lot of language and social emotional development occurs. A child begins to understand stories and begins to recognize those squiggly lines in that book, and they begin to make sense to them. They begin to learn story structure and have an awareness of print. It is not uncommon for a child to have memorized a book, and if you are a parent and wanting to get that child to bed because you've got something else to do, and you try to skip a couple of pages, that child is going to call you out and let you know that that is not okay. So these preschools have a sense of understanding, really even that early. And then they start learning basic reading and writing skills. And then there's the decoding for comprehension, learning to read and reading to learn. It switches from learning to read to reading to learn, and then you're into acquisition of knowledge. So language is a big, big part of academic demands. What do we see in kids who have learning disabilities? We see deficits in all of these areas. First is the phonological system. The PPMR there stands for 4 parts of the phonological system. The first is processing. The second is production. The third is memory. And the fourth, or the R, is retrieval. All of these components have to work together in the phonological system. We will see deficits in their writing, their semantic knowledge and use, the syntactic knowledge and use, and then pragmatic knowledge and use of pragmatics. We're going to look into each of these in more in depth. So let's think about a child with a history of speech sound disorder. What are his phonological skills? Even if he speaks clearly now that he's a school age after years of therapy, if he is to produce words that have a very complex sequence, such as Minneapolis, Minnesota, Philadelphia, Pennsylvania, Tallahassee, a child who has a history of speech sound disorder may continue to have trouble with these more complex sequences. Or even a child who didn't have a history of speech sound disorder but has a phonological system that's not real robust and solid, the child may also have trouble with producing these complex sequences. A child with weak phonological skills will exhibit different difficulties with phonological awareness and processing. First, the child will have difficulty with grapheme phoneme correspondence. This is where the child sees a grapheme or a letter and is able then to say the corresponding sound. Segmentations of words is where the word is broken apart into syllables or the different phonemes inside the word. One of the first phonological awareness skills to develop is rhyming. A child with a phonological system deficit can't figure out what rhymes together. Think about a child who is 5 and when asked, what rhymes with pig? And he says cow. What is he doing? His answer is a semantic association, not rhyming. The sounds can really mean nothing or make no sense to him. I have spent months working on a child learning how to discriminate words that even rhyme. So if you have a child who is having difficulty learning to read, you want to go back and really assess phonological skills. Can the child rhyme? Can he segment? Can he blend sounds together? Also, can he tell you what a sound a word starts with? Can they match a letter to a sound? All of these skills need to be solidified before learning to read. The child has to be able to hear a sound, hold it in memory, process it, and then retrieve it to produce it. Remember the PPMR? Having a child repeat back can assess a child's PPMR abilities. Writing is always impaired in some way with a child with a language learning disability. The child will often have a decreased expressive vocabulary, so of course we would expect the same decreased vocabulary in his expressive writing. Next, the writing composition will be poorly organized with minimal cohesion. Thoughts are just jump all around. The writing will also often contain the use of very simple and shorter sentences. These children often do not include many conjunctions to make it a cohesive sentence. For example, the child might say, I see a dog. The dog is black. The dog is running. Instead of saying, I see a black dog running. Their speech is often, and writing is often described as not efficient. For spelling errors, you want to, again, check that phonological system because spelling is just the opposite of reading. When you read something, you have to decode, match the letter to the sound. When you're spelling, you match the sound to the letters. So reading is decoding, and spelling is encoding. If the child has an impaired phonological system, then they will often rely on memory, so they will have sight words. They can't figure out how to sound out a word though. The child will only spell words that they have what is called mental grapheme representation, which is they can picture that word. So if I say to you, dog, did it come to your mind a picture? When I said dog, did you get a picture and did you see a dog in your head? Now, if I said, how do you spell dog? Do you see the letters? So that is the difference, is that the child who has that grapheme representation. Lastly, we also see difficulty with handwriting because the child doesn't understand the sounds in the letters. If he struggles to hear the sound, he's going to have a hard time matching the grapheme to the sound, and thus a lot of disconnects happen as he is trying to write the word. Also, these children will also often be diagnosed with dysgraphia, which is a learning disorder in the motor act of writing. So the children with learning disabilities are going to have a lexicon consisting of more basic words and words that are more concrete in their meaning. These kids will have difficulty with higher level metalinguistic skills, such as understanding multiple meaning words, figurative language, and implied meanings. Probably the most significant issue children with learning disabilities have is in retrieval. They can't figure out a word and they can't remember it. We've all done this where we say, oh, what was her name? Her name, it starts with an N, and you know, we did this and we did this and we went here, and man, I just can't think of her name. And then you stop and a few minutes later, boom, Nancy, her name's Nancy. You've all done this, right? I definitely do this. You remembering her name begins with an N or an N. That is a phonological cue. You have the semantic information and even picturing what Nancy looks like, but you're having difficulty retrieving the phonological information of the other sounds in her name. So this is a difficulty with semantic retrieval. You will also see a child that does circumlocution. This is a child who can't retrieve, like the word chair. The child thinks, It's something you sit on. It has 4 legs. Some of them have arms. Some of them have cushions, usually at a table. It goes with a table, or you might see it at a desk. So the child thinks of everything about that object except for the name chair. Another thing they do is substitute another word, often a more general word. So for the example chair, the child might substitute the word thing and say, it's that thing you sit on at a table. That one is very common, where they choose more general words than the specific nouns. The last characteristic that we see them do is interjections. They might say, or sometimes, and they'll just use this kind of talk because they can't figure out what they're going to say. And sometimes just that it's say, hold on just a minute, I'm thinking of it, I'll get there. That is definitely an use of interjections. If you see any of these characteristics, it means the child is having retrieval delays. We all have these, but the child with learning disability and language usually has a lot more of them. We see this in confrontational naming tasks. If an SLP is testing a child's vocabulary and shows the child a page that has 4 pictures on it, and you say, point to camel, the child will point to the camel. But if the SLP just shows them a picture of a camel and asks them to name it, they might not be able to. So this is why the child with learning differences will do better if it's multiple choice. If it's there for them to pick, the child can recognize it and repeat back the name. But if you're asking the child to retrieve the information, it's much more difficult. And I think all of you would agree with that or with this, that fill in the blank is definitely more difficult than multiple choice. In the area of syntax, an overall decreased mean length of utterance is seen. Characteristically, the children with learning disabilities will have short sentences and have difficulty with sentence comprehension. We see that these children might have difficulty with receptive and expressive understanding of syntax. Receptive understanding comes into play with oral communication and in reading. If you ask a child to point to the one who is running, the child may not know who to point to. Evidence shows that these children have trouble with the morphemes that are bound, such as the S and the ED. The auxiliary verbs like I am running, he is walking, and we are going, they often leave out, and they also often leave out the A and the. So do you notice a trend with all of these? The little syntactical elements that don't carry as much meaning or have a direct referent, they tend to have difficulty with these. Also, the more complex the sentence, such as point to the person who's wearing a hat on their hand, the more difficulty they will have, especially if a sentence like this that it doesn't really make sense, that we don't really wear hats on our hands. So with children with learning disabilities, we see a constant rate of learning syntax, whereas typical children will have a burst of learning syntax, then plateau, and then another burst. This difference in learning is also a clue of their learning disability. The last characteristic is that they might produce something, but may not comprehend what it means. I had a little one come up to me and say, "Why do you have dogs?" And I said, well, I have dogs because I like them to bark when someone's coming, or I like them to sit in my lap, and I like to pet, and I like to talk to them. And then I said to him, why do you have dogs? And he looked at me like he didn't understand what I was saying. And I said it again, why do you have dogs? And he said, I feed them. I said, yeah, that's what you do with them, but why do you have dogs? They go outside, he said. So he did not understand the questions, even though he could say it. So that's one of the funny things about syntax in a child with learning disabilities. They can repeat something often, but they don't understand it. Now with pragmatics, this is the most difficult area for nearly every child with learning disabilities because it involves conversation and interaction. And conversation goes very fast. I had a girl that was in high school and she told me that when she's standing with her friends and they're talking, that they talk so fast she doesn't understand anything they're saying at all. And I said, well, what do you do? And she replied, well, I just watch everybody else, and when they start laughing, I laugh. No idea what I'm laughing at, but if they're laughing, I'm laughing too. It makes me look like I know what they're saying. So poor thing, she's there and she really doesn't know what they're talking about, but she has learned how to look functional. So you'll see that as a big problem. This girl will seem normal during the interaction, but when it is her turn to talk, she can't formulate something appropriate to say, and she looks awkward or just does not take her turn sometimes. These children, when this happens, will look kind of quiet, right? They will not be the kids initiating a conversation or a topic, and they tend to wait and be more of the listener in the group. These children will also be the ones not telling stories or narratives with their friends. These kids will also have trouble with lingo and slang, which is very important in the pragmatics of a young person, right? When an SLP wants to check with the teacher about how the child is doing in the classroom with language, the best thing to do is give the teacher a pragmatics checklist, because pragmatics tells us how the child is using their language. What is their behavior with language? Things that we can see. We don't want to ask them how's their syntax, how's their vocabulary words. That's hard to measure for a teacher, right? In everyday functioning. It's much more easier and functional to say, do they ask questions? When do they ask questions? Is it appropriate? Do you see them having conversations? Different things like that. Now we're going to discuss specific language impairment and learning disabilities. A child who has a language disorder is likely going to be classified as specific language impairment up until they possibly become diagnosed with a learning disability. A lot of professionals see learning disability, or LD, as just a continuation. A lot of children have what we call illusionary recovery. This is when a child is in therapy, they get caught up to where they look and appear like they are doing very well and functioning like other children. But in reality, they're not exactly where those children are. Once a child went up to a higher step, or once a child goes up to a higher step, that child might be on the higher step, but then the children that are already there are getting ready to leave that step. And that child's just getting there. But then eventually, so they're there, but what we see is the other kids are moving on, and they might move on quicker. So eventually that gap gets bigger and bigger, and the child gets farther behind. An example of this could be a child who was in therapy and upon reassessment scored somewhere in the 90s. He did well with isolated specific questions such as what is this, what is that, so he did well on the test. But upon observation in the classroom, we could see a different story. I have seen kids like this do well on the test, but then functionally they're very different with their peers in the use of their language, kind of like we talked before. They have difficulty putting it all together in that moment. So that child that I just talked about would be called having illusionary recovery. So the test scores look good, but the actual ability to use that language is not good. A lot of times these deficits continue through high school. So remember, a history of SLI should be considered a significant risk factor for learning disability, even if a child is no longer qualifying for services. This slide is a review of SLI and what is seen. Age 2, less than 50-word vocabulary and not using two-word phrases. They don't have any other problems. They seem to do just fine in every other type of development. Their nonverbal development is not normal, their gestures are fine, their play is fine. They can also take care of themselves. Their motor skills look good. But for some reason, I love this phrase from Leonard, they fail to learn language rapidly and effortlessly. And then, of course, there is no known cause. We see in preschool that these children who will be later diagnosed with SLI may be only slightly behind, but as they progress through the different grades, we see that what they learn is at a slower rate. This is kind of what we just talked about. So eventually that gap increases over time. It's kind of like running a race. If you're starting off in a race and say it's a 1500 meter you're running, you may start off fine with the person who's going to make it all the way, but over time you get a little bit behind, then a little bit further, then a little bit further, and then you get even further behind. This is exactly what happens to children if they don't get services and additional supports. That gap just gets bigger and bigger. This is called the Matthew effect. This is from a book in the Bible, the book of Matthew, where they say the rich get richer and the poor get poorer. In this case, the child with learning disability gets further and further behind. So you'll often hear that phrase, the Matthew effect, when you read in the literature about learning disorders. Up to this point, we've discussed children who have had a language delay in the past, who then move into language-based learning differences and disabilities. Think about this question, though, for a second. Why do some children without a history of SLI develop language-based learning disabilities? There are several possibilities for this question. First, the child may be able to manage spoken language but have difficulty with written language. Second, the child might have been typical developing in the basic language skills and concepts, but have difficulty with the higher language and metalinguistic skills. Third, they may have some home language, but not academic language. The second and third points might overlap in a lot of kids. Lastly, specific language weaknesses may not become apparent until the child tries to learn to read and write. Maybe the difficulties were subtle enough before that they were functional in their oral language, but higher demands now show their weaknesses. Here's some more characteristics. Remember that performance IQ is always higher than 85. A child's overall IQ is made up of performance and verbal. Performance is usually timed and it's like matching puzzles and things. The child will be asked to match shapes and show a pattern and asked to match a pattern. These tasks do not involve language, but their verbal IQ, it does involve language, thus it is lower. So you have to remember that an IQ can be deceptive if you're looking at the full score scale. So if you have a child you suspect of a language disorder, you want to look at not just their full scale IQ, but you want to compare their performance IQ to their verbal IQ. Children with SLI also have poor expressive skills. They understand more than they can say. Verbs and morphemes give them a great deal of difficulty. Group activities are difficult because they have trouble socializing and planning and organizing, so they don't work well in groups. These children also often don't know when they don't know. So they just keep on going and thinking that they're doing right. Their self-awareness skills are known to not be as good as typical developing children. They also have retrieval problems and inefficient processing, which are tied into working memory capabilities. Lastly, these children will have more self-regulation difficulties, where they seem to have what we call emotional lability or lability, where they cry and they laugh more easily. This slide is a review within the organization of content, form, and use. Take a second to pause the video to read over this. Now we're going to go into auditory processing. In the past, this was called central auditory processing disorders. The diagnosis of auditory processing disorders must include deficits in the central auditory nervous system. Auditory processing begins at the cochlear nuclei in the brainstem and ascending up into the cortex. So auditory processing and language processing are not the same. Auditory processing is that conversion of acoustic stimuli and the processing of that information in the auditory cortex of the brain. Processing of language or receptive language abilities is a whole different process. So to receive a diagnosis of auditory processing, auditory and hearing acuity and IQ are within normal limits. Assessment of the auditory nervous system is conducted by an audiologist. This is why an auditory processing disorder has to be diagnosed by the audiologist. We see, though, that the SLP has to also be a part of the assessment process because they often have language processing also besides the auditory processing, and then also memory problems. So really both of these need to be looked at simultaneously and then also treated simultaneously. So ASHA says a child must be 7 years old or older to diagnose APD. This is because we need time for language skills to develop and the auditory processing system to mature. Many of you know that some of my research and clinical interests are in auditory processing disorders, and so I've done a lot of research and looking at what are the auditory processing deficits. I work very closely with Dr. Erin Schaefer in our department, and we have had several different studies in looking at it. And auditory processing is really a pretty new and still very much evolving field. So there are different groups kind of within the auditory processing world, and it really the deficits of auditory processing are defined a little differently between these groups. But I am giving you the information for probably the most populous group and the one that Dr. Schaefer and I kind of work from. So there are these specific auditory processing, 7 different auditory processing skills that we look at. So not all children will have difficulty in every one of these areas. So it's up to the APD to assessment that the audiologists and the speech language pathologists do to differentially diagnose these areas. So the first is speech and noise. This is the identification and recognition of speech in the presence of background noise. I think this is the one that most people kind of think of with auditory processing. It's definitely a very functional and very widespread auditory processing difficulty. The second area is auditory filtering. This is looking at a person's distractibility in background noise or their overreactive responses, and then any failure to respond, which is their responsive response to stimuli. The third is interhemispheric transfer. This is the transferring of auditory information from one hemisphere to the other. The fourth APD deficit is in temporal processing. This is the rate at which we can process auditory information. Temporal processing affects what we call gap listening. So the ability to use the brief, relatively quiet periods that occur in environmental noise to access the speech signal. The fifth is spatial processing. This is the detection of subtle interneural difference cues to improve speech perception and noise. So where is the sound coming from? The sixth is working memory and comprehension. This is the short-term storage of auditory information and understanding of the meaning of the verbal message. This is the one that SLPs work on very regularly. Lastly is everyday processing. This is the overall listening abilities as perceived or observed by a listener, parent, or teacher. This is the functional abilities as seen in one's everyday environment. So this is a good big picture slide of auditory processing. All of these areas of auditory processing interact, and there's research evidence suggesting that many of these types of processing are significantly correlated. We also want to be clear that the areas that we plan to further research are not only areas to assess or the only factors that affect auditory processing. So that's what are these factors that are on the outline areas of this slide that came up last. So many of these other factors affect auditory processing. So it's the working memory and the comprehension, expressive and receptive language, auditory attention, executive functioning, which is our ability to plan and organize and sequence our world, coexisting disabilities that they might have. So do we have some sensory process, some other types of sensory processing disorders? And then their ability to localize sound and lateralize sound. So these other factors and many more relate to auditory processing in all populations. Especially without the audiological assessment piece, differentiating from a language disorder is difficult. Most children with APD also have significant problems with language comprehension. So we're going to be, most of the time, working on both. In many public schools, though, APD is not a qualifying condition for special education. Children can only qualify if they have a language disorder also and show an educational need. I really hope this changes as we have more research in APD and learn about the diagnosis and the intervention that is needed. So children with APD will often have difficulties with these areas also: reading, spelling, handwriting, articulation, and language disorders. Makes sense. If a child can't understand what is coming in, then they're going to have difficulty in these areas also, right? So this wraps up Chapter 8. Next week, we're going to go into more detail on spelling and reading disorders in Chapter 9 and ADHD in Chapter 10. Have a good week.